Hello all, this is discussion on granulomatous disease pertaining to respiratory system. So the first one is sarcoidosis. Sarcoidosis is a systemic granulomatous disease. So the term systemic says it involves multiple organs and tissues. The most common organs are your lung, lymph node, eye and skin. These are the most commonly involved organs. Apart from that, the other organs and tissues are also involved. And it is a granulomatous disease. So it produces a non-caseating granulomas, usually seen in adults younger than 40 years of age and higher in women. Pathogenesis. Etiology of sarcoidosis remain unknown. However, some researchers have said it is due to a disordered immune regulation in genetically predisposed individuals. So the two components, one is genetically predisposed individuals and other one is disordered immune regulation. So looking into genetic factors, HLA-A1 and HLA-B8, these are the two HLA genotypes linked with sarcoidosis. Next, immunologic factors. Intra-alveolar and interstitial accumulation of CD4 T cells. So, the CD4 T cells in sarcoidosis patients are accumulated in the alveoli and interstitium. The CD4 to CD8 T cell ratio is increased. It ranges from 5:1 to 15:1. Apart from that, there are certain increased levels of T cell derived cytokines, namely interleukin 2 and interferon gamma. There are even other cytokines increased in the local environment, interleukin 8 and tumor necrosis factor. Also, impaired dendritic cell function is seen, allergy to common skin test antigens. So these are some of the statements which says there is a immunologic factor in the pathogenesis of sarcoidosis. Looking into the morphology, it is a granulomatous disease. So definitely there will be a granuloma. This granuloma is a non-necrotizing granuloma. Unlike your TB granuloma where there is a caseous necrosis in the center, here there won't be any necrotic center at all. So it is a non-necrotizing granuloma but composed of epithelial macrophages and often the giant cells. Next is the Schwamen bodies. The Schwamen bodies are nothing but laminated concretions composed of calcium and proteins. So on histologically, you can see certain concretions which are composed of calcium and proteins. These are Schwamen bodies. And the other one is your asteroid bodies. That is, it is a star-shaped inclusion which is seen in a tissue biopsy in a sarcoidosis patient. Both of these are seen in 60% of the granulomas. They are characteristic of sarcoidosis. However, they are not pathognomic of sarcoidosis. Now, talking about the individual organs, the first one is the lung. Lung involvement is seen in more than 90% of the sarcoidosis patient. So, the first one you can see the granulomas. These granulomas can coalesce to form small nodules. All these granulomas can join together to form small nodules which are palpable or visible. They are usually seen along the lymphatics. Apart from this, you can also see fibrosis and on histologically you can see the ionization pattern. So these are the two things. One is the granuloma and the next one is the fibrosis. These two things can be seen in the lung. Lymph node. Lymph node involvement is seen in almost all the cases. Especially the mainly involved lymph nodes are your hilar and mediastinal lymph nodes. These two lymph nodes are involved in almost all cases and you can see a enlarged, discrete, fibrosed and a calcified lymph node. So the lymph node will be fibrotic which later undergoes calcification. It will be enlarged. So this is about the lymph nodes. And the next organ is your skin lesions. Skin lesions is also seen in one fourth of the sarcoidosis patient, it can have variety of appearances ranging from just a subcutaneous nodule to a erythematous plaque or even a flat lesions. So it can have a different a variety of appearances. And also the mucous membrane of the oral cavity, larynx and upper respiratory tract are also involved in sarcoidosis. Next is the ocular involvement. This is also commonly seen in sarcoidosis patient, around 1/4 of the patient. In this, initially you will have the iridocyclitis, which later on develops into the corneal opacities and glaucoma, and ultimately it can lead on to total loss of vision. So the ocular involvement, the initial clinical manifestation is your iridocyclitis, which may even ultimately lead on to loss of vision. In this, you have something called Mycolic Syndrome. So what is this Mycolic Syndrome? It just told by one word, uveoparotid involvement. That is, your lacrimal glands as well as your parotid and the other salivary glands, that is your submaxillary and the sublingual glands. All these glands undergo inflammation. So this is called as your Mycolic syndrome. And since the lacrimation gland undergo inflammation, there will be decreased lacrimation, that is the tear production will be reduced. Next is spleen. So spleen, you can see granulomas which coalesces to form the small nodules. There will be enlargement, and even in liver also there is moderate enlargement and granulomas. Bone marrow. In bone marrow, basically it involves the phalangeal bones of the hands and feet, and histologically you can see a circumscribed area of bone resorption. There will be a well circumscribed localized region of bone resorption in the phalangeal bones of hands and the feet in sarcoidosis patient. Next is the muscles. Muscles, usually they are, in case if muscles are involved in sarcoidosis, they are usually asymptomatic. However, the clinical symptoms can say muscle weakness, ache, tenderness and fatigue. With these clinical symptoms, you can think of always a sarcoid myositis. And it is usually diagnosed by biopsy, but when only the muscles are involved, the patient is usually asymptomatic or they have a generalized feature like fatigue. Next is heart, kidneys, central nervous system and endocrine glands. These are also involved. And central nervous system, it causes neurosarcoidosis, which is seen in 15% of the patients with sarcoidosis. Okay. Now moving into the clinical course. So since it's a systemic granulomatous disease, it presents with diverse features. However, when it presents to a clinician, it generally presents due to some respiratory abnormalities. Most probably a shortness of breath, cough, chest pain or hemoptysis. Because of these symptoms, he presents to a clinician. And sarcoidosis, it is a disease of diagnosis of exclusion. Diagnosis is made based on exclusion because it involves the multiple organs. Also, when it pertains only to lung, it looks very similar to it causes interstitial fibrosis. So it causes similar to your idiopathic pulmonary fibrosis. Apart from that, the granulomatous lesions, it's not only seen in sarcoidosis, it can be even seen in your hypersensitive pneumonitis, it can be seen in your berylliosis, it can be seen in your TB. So because of all this, the sarcoidosis is always made a diagnosis of exclusion. So along with the respiratory abnormalities, it can also have other signs and symptoms like fever, fatigue, weight loss, anorexia, night sweats. And once its sarcoidosis is diagnosed, its clinical course is also unpredictable, but in 65 to 70% they recover without any residual complications or manifestations. However, in 20% they have some permanent loss of lung function or visual impairment, and 10 to 15% die of cardiac or central nervous system damage, that is your neurosarcoidosis. So only 10 to 15% of the patients die while rest of them may have some or no permanent damage. And next, your granulomatous disease is your hypersensitivity pneumonitis. So, what is this hypersensitive pneumonitis? It's basically a type 4 hypersensitive reaction to a organic antigens exposure. So, on exposure to certain organic antigens, some of the people develop a type 4 hypersensitivity reactions. This is called the hypersensitive pneumonitis. Because of this hypersensitive reaction, what happens? There will be a alveolar wall, especially the interstitium gets damaged. What happens? The inflammation occurs, which lead on to your fibrosis. Along with it, you will have the granuloma formation. So your hypersensitive pneumonitis is also called as extrinsic allergic alveolitis. This term specifically says alveolitis because in HSP, only the alveoli, especially the interstitium, is mostly affected due to an extrinsic allergic factor. So HSP is also known as extrinsic allergic alveolitis. Okay. So since we have said organic antigens, let's look what some of the organic antigens. So one of the HSP is your farmer's lung, which is the most common. It is due to, so the farmer's lung, you need to have organic antigens. So what are the organic antigens? It's basically your thermophilic actinomycete. This is the antigen which is present in the warm harvested A. So in the warm harvested A provides a fertile ground for the spores of the thermophilic actinomycetes. When these actinomycetes enter into the respiratory tract, it can cause your HSP, which is called farmer's lung. And the next one is the pigeon breeder's lung or bird fancious disease due to proteins from the excreta or feathers of birds. Next is your humidifier or air conditioner lung. In this, the major organic antigen is your MAC, that is your Mycobacterium avium complex. These are the major organic antigens. And compost lung, which is also one of the commonly seen, is your compost lung, and in that you can have your Aspergillus clavitus. So these are some of the HSPs and the organic antigens. Okay. So pathogenesis, as already said, you are exposing yourself to the organic dust, and it does not happen in all the patients, to some sensitized individuals. So when these sensitized individuals exposure and they inhale the organic dust, a type 4 hypersensitivity reaction, that is a T cell mediated reactions develop, which lead on to formation of granuloma and fibrosis. So this is what the pathogenesis is. Okay. So the fibrosis has occurred. Next is your bronchoalveolar lavage specimens. So in these patients, you can basically see the fibrosis of your interstitium. So moving on of the interstitium. So when you move on to your diagnosis, you take a ball, that is your bronchoalveolar lavage. On taking, you can see two things. Pro-inflammatory chemokine, that is your macrophage inflammatory proteins 1 alpha and interleukin 8 are increased, and also the CD4 and CD8 T lymphocytes are also increased. But here you see the CD8 to CD4 ratio is increased, whereas in your sarcoidosis the CD4 to CD8 ratio was increased, but here it is the reverse. Here the CD8 cells are more increased. So CD8 to CD4 ratio is increased. And other things, when you look into the serology, most of the patients will have specific antibody against the causative antigens. So when you take a chest x-ray, you can see a certain fibrosis pattern. Apart from that, when you see the pulmonary function test, you can have a restrictive pattern. And when you have a CT, when you do a CT, you can have a mosaic attenuation pattern or HE's pattern. So these are some of the investigations: X-ray, CT, pulmonary function test. And in your BAL, you will have CD8 to CD4 ratio increased. Apart from that, you can have the specific antibodies. Next, going on to the morphology, which is the important one. In morphology, as told before, you have your type 4 hypersensitivity reaction, which lead on to your inflammation and fibrosis as well as granuloma. So the inflammation, you will have the interstitial pneumonitis, where you can see lymphocytes, plasma cells and macrophages. Also, you will have, which will lead on to interstitial fibrosis, which will cause your obliteration of your bronchioles, that is obliterative bronchiolitis. So inflammation and fibrosis, this is one. And the next one you can see is the non-Caseiating Granuloma, which is seen in 2/3 of the patients. So here you can see a granuloma picture. Here also it is a non-necrotizing granuloma, surrounded by you have the epithelioid as well as your giant cells. Next, the clinical course. So on exposure, it is a hypersensitivity, so it's a delayed hypersensitivity reaction. So after exposure to 4 to 6 hours, the symptom starts appearing and it lasts for up to 12 hours to several days. So generally you will have fever, dyspnea, cough and leukocytosis. These are the general symptoms they will have. But on recurrent or in a prolonged exposure, this HSP can turn into a chronic form. So once it turns into a chronic form, it can cause a progressive respiratory failure and cyanosis and dyspnea can occur. So when it turns into chronic form, there can be a deteriorating pulmonary function. So this is about your HSP and sarcoidosis. Thank you.